areas. In the next several months, you're going to see several initiatives being rolled out throughout the hospital. I think after reading through Dr. Phillips's CV that she's involved in almost every single one of them to really try and work on controlling the opioid epidemic locally for our patients and for the healthcare community, and also to give our providers a little bit of help in doing so. So Dr. Phillips has been gracious enough to come today and talk with us a little bit about multimodal pain management and the opioid epidemic that we're all up against at this time. And I've been given the privilege of introducing her this morning. I did not realize until we looked through her CV that we actually went to school in South Carolina together, right across the state. And she is a graduate of Clemson, and I'm a USC fan. USC from medical school as well as undergrad. So we will have to put those differences behind us and take those behind closed doors. But she further went on to the beautiful city of Charleston, where she attended MUSC for medical school. If you've never been there, I highly suggest. It's a beautiful campus and awesome school and a beautiful city. She then went on to Chapel Hill, where she did her residency in anesthesia, and further on to Vanderbilt, where she did a fellowship in pain management. She had a little bit of time in interventional pain management, and then we were lucky enough to recruit her to Christiana about a year ago, and she's been here as the medical director of the pain service since that time. I've worked with Dr. Phillips on multiple committees. She is a true pleasure to work with. For those of us, and I assume that's probably all of us now, that are dealing with chronic pain patients as well as polysubstance patients, she's truly been a godsend. So if you haven't met her or been familiar with her yet, even though she's kind of a small service, I highly recommend that you work with her. And without further ado, I'll introduce Dr. Irina Phillips. Please give her a warm welcome.
Good morning. Thank you all so much for having me. I really appreciate the opportunity to speak with you this morning. As she mentioned, we're going to be talking today about postoperative pain management and the responsible use of opioids. We're going to go over a few things this morning. We're going to start by talking about why is it important to care about acute postoperative pain management, and we're going to spend a little bit of extra time talking about chronic post-surgical pain. We're then going to get into the meat of it, how do we better provide adequate pain management for our patients, both through pharmacology as well as non-pharmacologic methods. And then lastly, we're going to wrap up by talking about, as she alluded to, some of the current initiatives that we have underway here at Christiana to try to provide better pain care for our patients. So why does this matter? So many of you probably would not list pain management in your top 5 topics of favorite things to think about. And in fact, it probably isn't in the top 10 or top 20 for many people. No one likes to think about pain, but it matters. And it matters first and foremost just because of sheer volume. A healthcare market research firm indicated in 2013 that worldwide there were 232 million surgeries performed. So this is a tremendous number of patients who are potentially undergoing painful procedures and who may have issues with perioperative pain management. Now, you would think, based on these numbers, and as long as we've been providing surgery to patients, that we would have it figured out by now. How do we provide excellent perioperative pain management? But both clinical experience as well as research has indicated that we actually have a little bit of work to do. Now, again, we are going to start out by talking about why it's important, and then we'll get into the meat of how we actually provide better pain care. So here's just a little bit of information on how we're doing right now. In 2014, there was a phone survey of about 300 patients. They asked these patients if they had pain after surgery and how was it. 86% of those patients said, yes, I had pain after surgery. Now, that's not unexpected. Surgeries are painful procedures potentially. But the more telling thing is that 74% of these patients said their pain was moderate to severe after discharge. So we have a large number of patients who are going home after surgery and are continuing to have significant pain. We know that this can negatively impact a patient's quality of life, and it can slow down the time of them returning to their preoperative function, which is, we want to get them back to functioning well. That's the purpose of many of our surgeries. Besides just patient experience, there are other things that we need to think about when we talk about acute postoperative pain. And the first of which is there's the potential for dangerous physiologic alterations if you have poorly managed acute post-op pain. The cardiac and pulmonary systems are the two most commonly affected systems. Patients with really bad pain postoperatively can have tachycardia, can put them at risk for myocardial ischemia if they're a patient with some underlying cardiac disease. pulmonary complications like splinting, atelectasis, potential for development of pneumonia. You all have seen this in your patients who don't seem to be comfortable postoperatively, that we can start to get into some medical issues. Beyond just that, we know that poorly controlled pain can impact length of stay. So particularly in ambulatory surgery, pain is one of the top 3 reasons why patients have a delayed discharge in addition to nausea and drowsiness. So this suggests economic implications beyond, again, just patient experience. This matters to the bottom line if our patients are staying in the hospital longer because of poorly controlled pain. Lastly, we're going to talk about the development of chronic postoperative pain. And we're going to spend a little bit more time talking about this morning because this is becoming recognized as an important postoperative complication that we really need to spend some time thinking about. So first, let's define what it is. There are a couple different definitions floating around out there, and this has made kind of data gathering difficult because there's not one uniformly accepted definition. But here's one proposed by McCrae and colleagues. Obviously, chronic post-surgical pain has to develop after the surgical procedure, so it must be related to the surgery that was performed. It can't be related to any pre-existing pain. It must be present for at least 2 months postoperatively. So this, excludes that acute postoperative pain that may take some time to resolve. And there can't be any other identified etiology. So this can't be your patient who has a known complication after surgery that may potentially be causing pain. We have to exclude those patients to say that they qualify as having chronic post-surgical pain. Now, a conservative estimate, again, because the definitions are kind of varying in the different studies that have been done, but a conservative estimate is that about 10% of all postoperative patients are going to go on to develop chronic pain. And I could be wrong, but I suspect that when you all are consenting your patients preoperatively, you may not be discussing this as a possible complication. You probably spend a lot of time talking about bleeding, infection, damage to adjacent structures, or whatever it is you consent your patients on. Here's just a survey looking at what patients heard in their consent process. About 1,000 patients were asked, did anyone talk to you about chronic post-surgical pain? And 80% said no. Now, maybe it was discussed and they don't remember, but this is the take-home, is that 80% of those patients said, no one told me about that. And furthermore, a quarter of those patients said they thought their chance of developing this was 0, which we know is not true. 10% of them will develop chronic pain. So our patients may not be as informed about this possibility, and it is something that's important to discuss so that you can kind of better align patient expectations with possible outcomes. Now, similar to non-surgical chronic pain from surgery can also have significant economic implications. We mentioned kind of length of stay impacting economics, but let's just talk about the care of chronic pain patients. Now, this is chronic non-surgical pain patients, but Institute of Medicine released a report in 2011 that estimated we spend $600 billion annually on the care of chronic pain patients. This is both direct healthcare related costs as well as indirect costs. This is just comparing it to heart disease, cancer, and diabetes. It is, double the amount that we're spending on chronic pain. So this is really impacts all of us, even if you're not a patient personally with chronic pain. It's impacting everyone. So what is chronic post-surgical pain? How does it develop? There's research looking into this right now. We don't have all the answers, but we think we have some mechanisms for how it develops. And this is kind of similar to what we think happens with non-surgical pain as well, as far as establishing that chronic pain. So it starts in surgery anyway with a surgical nerve injury, or may not even be a nerve injury, just tissue damage from incision or the surgery itself. So with this initial tissue damage, you start to have a nociceptive input. So that's appropriate. The body, responds by upregulating those inputs. And then at the level of the spinal cord, specifically the dorsal root ganglion, you can start to have the development of peripheral sensitization, where this means all of a sudden our mechanical thresholds are lower and we may have an exaggerated response to that noxious input. The changes continue on up to the level of the brainstem and the brain. Here we start to develop central sensitization. So again, the signals continue to be propagated upward towards the brain, but what also can happen at this level is we start to lose some of the inhibitory signals coming down the spinal cord that would normally quiet down those pain signals. We start to lose that. And now these pain signals are just going unabated up to the level of the brain. And then at the brain level, as it kind of settles in as a chronic pain syndrome, we start to have involvement of some of the emotional centers of the brain as well. And I'm sure just from personal experience, many of you have taken care of chronic pain patients who also have issues with emotional distress as well. This is not in their head. This is very real. They actually have changes in their brain that are going on with this constant chronic pain input. So I try to tell my chronic pain patients that it isn't in their head, that I do believe them, that they have pain, that there may not be easy ways to fix this, but it's very real. They often appreciate a little bit of validation that this is real. They're not making it up. So that's kind of what we think happens in chronic pain development. We've got peripheral sensitization and central sensitization. Those are two kind of buzzwords that you'll hear a lot when you're talking about chronic pain. Most often, although not always, this type of pain is neuropathic pain. And what that means is nerve-like pain. Patients may describe burning type pain, but they can obviously have pain that's characterized in different ways as well. Now, what is the incidence of this? So I've got a couple studies here. There are certainly certain procedures that have been identified as more likely to go on to developing chronic pain than others. Here's a study from 2008 by McCrae, who looks at the rates of chronic pain. May be difficult to see here, but amputation is the most likely to have patients that go on to develop chronic post-surgical pain, up to 85% of patients having an amputation. Thoracotomy is the next most likely, followed by cardiac surgery, and the fourth is mastectomy. So these are pretty high rates of development of chronic pain if you're looking at the upper end of patients here. Here's another study that actually had similar findings. This is from The Lancet in 2006. Their rates are a little bit lower, but same top 4 surgeries, amputation being one of the most common, cardiac surgery, thoracotomy, and breast surgery. So that right there, tells us that there are certain procedures that are more likely to go on to develop it. So is there anything we can do about the development of chronic post-surgical pain, or is it something that we just have to accept is going to happen to about 10% of our patients? There are some things we can do, but the first step in doing that is trying to identify those patients who are at risk. And as someone mentioned in a talk yesterday, many of you, when you meet your patient for the first time in pre-op, you probably already have like a spidey sense about that patient, and you may already be able to recognize that's a patient who's really going to struggle with pain after surgery. It's just that feeling you get about the patient. There are some actual risk factors that we have identified. Here's the patient-related factors, and to a large degree, these are not modifiable factors. So young females are more likely to develop chronic pain, and patients who have certain psychological traits like mood disorders, so depression, anxiety. Catastrophizing is another characteristic that we associate with higher rates of chronic pain. For y'all that don't know what that means, basically that's an exaggerated pessimism about the outcome. So you have those patients who seem to really expect the worst. That's not a good prognostic indicator for a patient with regards to chronic post-surgical pain. In addition to patient factors, there are some medical factors that have also been identified as risk factors. The presence of pre-op pain. This kind of goes without saying, but in patients who have pain preoperatively, they're more likely to have chronic pain after surgery. And there's a couple modifiable factors in here. We're not going to spend time talking about this today because I'm not a surgeon, but obviously longer durations of surgery are potentially associated with higher rates of chronic pain after surgery. Surgical approach, open procedures are more likely than laparoscopic procedures to lead into chronic pain after surgery. So these are things that as surgeons you can potentially modify, depending on what procedure the patient's having. And lastly, the presence of acute postoperative pain that's poorly managed or poorly controlled does put patients at higher risk for going on to develop chronic pain. And this has been shown in a variety of surgical procedures. So what we're hoping to achieve by improving our postoperative pain management is we're trying to reduce the risk to these patients of going on to become chronic pain patients. We can't change the fact that they're young females with depression, but we can change some of these modifiable factors in the postoperative period, specifically acute pain. So this brings us to our primary question. We know that postoperative pain is associated with a worse patient experience. We know that it can impact certain elements of a patient's physical recovery and can also present dangerous kind of physiologic alterations. And we also know it puts people at risk for chronic pain. So what in the world do we do, and how do we do it better? This is a really neat picture that I found from one of the original Wilmington ORs in the 1890s. So the data I'm going to present to you today is going to be focusing on both the pharmacologic and non-pharmacologic ways that we can treat pain. There are a lot of different societies out there that have proposed guidelines to help lead us in the right direction with perioperative pain management. I'm kind of going to loosely follow the guidelines presented by the American Pain Society, who had input from American Society of Anesthesiologists, American Society of Anesthesia, and Regional Pain Medicine. They all came together in 2012 and came up, based on a exhaustive literature search, some recommendations for perioperative pain management, and then they revised these in 2016. So I'm going to be kind of loosely presenting these guidelines to you today. The first is my favorite buzzword in pain, multimodal analgesia. I'm sure y'all have heard of this word before. I don't know if you've read it in my notes. I write it a lot. But this is kind of the crux of what we think to be best practice as far as postoperative pain management. And many of you already know what this means, but for those of you that don't, what this means is you're using several different either medications or non-pharmacologic ways that all work with different mechanisms of action to synergistically work together to provide pain management. All the various things we have available, I'm not expecting you to read all these things in blue here, but there are lots of different analgesic options for patients, and they all work at different spots on the pathway from the periphery on centrally. And in general, what we're hoping to do by using all these different types of medications is we want to, of course, improve analgesia. We want to provide better pain relief to our patients. We want to achieve an overall dose reduction because we know that certain doses are associated with certain side effects. It's really primarily opioids that we're hoping to reduce as far as doses and side effects. Y'all are all probably very familiar with the side effects of opioid medications. We've got sedation, respiratory depression, nausea, vomiting, ileus, urinary retention. There's a lot of downsides to opioids, even though they're great analgesics. And so the more we can do to reduce the doses, the better our patients will do. So we're going to talk about a couple of different agents here on this pathway, both medications as well as non-pharmacologic things that we can do for pain. We're going to start by talking about the OG, heroin hydrochloride, the original opioid. And we're going to spend a little bit of time talking about opioids because this is something, obviously, if you turn on the news for 5 seconds, you have heard about the current issues with opioids. So we're going to spend a little bit of time talking about this today. Opioids are a fantastic analgesic, and they absolutely have a place in pain management, definitely acute postoperative pain management. But we do have some things we have to be careful about. Interestingly, just a tidbit, so heroin got released by Bayer Pharmaceuticals in 1890. It was released as a cough, cold, and pain remedy, and I saw some really cute advertisements directly encouraging use in children. So there was dependence that developed with the persistent use of heroin, as you might imagine, and actually in 1924 it was banned for use except in extreme circumstances. Thankfully, they went on to develop some other synthetic opioids that were perhaps a little bit safer to use, but heroin is obviously no longer prescribed, we'll say that. So let's get a little bit of background information on how did we get here to this current opioid crisis that we're in. And, I'm sure, all of you either know someone personally who has a problem with opioids, or if you don't know anyone personally, you have absolutely taken care of a patient who has an opioid problem. So this really impacts everyone. But there were a lot of things that went into kind of bringing us to where we are today, but I'll kind of just touch on some highlights. So back in the 80s, we were kind of mainly using opioids for cancer-related pain. There were a couple different papers that were published around this time, but one that always stands out in everyone's mind is from 1986. So Dr. Portnoy is a physician who published a case study. He had 38 patients who did not have cancer but had chronic pain, and he decided to use opioid medications for these 38 patients. Only 2 of his patients went on to develop opioid use disorders, and these 2 patients had prior issues with opioids. So his conclusion was this is a safe, long-term option for patients with chronic non-cancer pain. Now, obviously, this is a small paper. It's only 38 patients, but it really opened the doors for others to start thinking about this. Oh, maybe opioids are a good option for non-cancer pain. So others kind of started to get on board and use opioids in their patients. In the 1990s, OxyContin came on the market. Now at this point, patients, they were needing a drug to help provide long-term pain management for patients, and OxyContin came to the rescue. The advertising or the pharmaceutical industry made really big advertising pushes for their medications. Direct-to-consumer marketing, they had, promotional videos that they would play in the waiting rooms of physicians' offices to really encourage the use of long-acting opioid medications. In the 2000s, the Joint Commission mandated that we assess pain in all patients. So kind of our governing body said pain is the fifth vital sign. This is something we need to be paying better attention to, and we need to do better at treating our patients. Interestingly, there was an educational book published in 2000 by the Joint Commission targeting physicians that stated, quote, "There is no evidence that addiction is a significant issue when persons are given opioids for pain control," end quote. So again, we are kind of being led to believe that the presence of pain is protective against addiction at this point. Obviously, hindsight is 20/20, but at the time, this is what we knew, and we were being encouraged to use these medications. And then this brings us up to kind of current day and what's going on. Over the past 15 to 20 years, we have seen a tremendous rise in the use of prescription opioids as well as illicit opioids. And here's just an interesting graph kind of showing you the steady rise in prescriptions. So hydrocodone's in red, oxycodone's in green. For those that don't know, hydrocodone is Lortab or Vicodin, and oxycodone is Percocet. So here's 1991 to 2009, and it's just this beautiful rise upward of prescriptions. And it stops in 2009, but it actually continues to rise a little bit after that. It's been estimated that the United States accounts for almost 100% of the world's hydrocodone use, and we have about 81% of the world's oxycodone use. So we're really doing our part for Lortab and Percocet to keep them in business. This probably doesn't come as shocking information to anyone, but the CDC has estimated that 91 Americans die every single day from an opioid overdose. So this is a tremendous, tremendous problem. Now, we would like to think that, well, let's back up a little bit. So there are many things at play here with the development of the opioid crisis. And as physicians or as prescribers, we do have a part in this. And there is a role that we have played, and there are things that we can do differently now that we have all this information to try to kind of turn the tides. We'd like to think that all of our patients are taking these medications exactly as prescribed. You tell a patient take one Percocet every 8 hours as needed, and you'd like to think that's what they're doing. Unfortunately, y'all probably know this clinically, and we certainly know this with research now, but unfortunately our patients are not necessarily following those instructions. About a quarter of our patients who are prescribed opioids are misusing them. 8 to 12 of these patients are going to go on to develop a opioid use disorder, and 4 to 6% of these patients are going to transition to heroin. So this is a lot of our patients that are being prescribed opioids appropriately for certain conditions that are going to go on to develop a problem. 71% of those people that are using prescriptions are getting them through diversion, and what that means is they're getting them from someone else. It wasn't prescribed to them. 55% of those patients who get them through diversion are getting them from family and friends who have excess pills. And the reason I highlight the word excess, this is where we come in as the prescribers. We are certainly playing a role in these excess pills being out there in the community. These are the patients who maybe they have a surgery, you give them 60 Percocet, they take 4, they put the bottle up in their medicine cabinet. Maybe another family member says, I have a headache, they hand that family member a Percocet, and the rest is history. Or maybe they have young people living in their home. I'm not that young anymore, but I hear it's cool to take pills at parties, so the young people might be rummaging through the parents' medicine cabinet and getting access to these opioid medications. I hear this time and time again from patients who have an opioid use disorder that this is how it started. They first were given the medication by a well-meaning family or friend who they expressed a pain complaint, someone shared a pain medicine, and then for whatever reason that patient went off the rails and now has an opioid use disorder. Looking a little bit about opioid prescriptions postoperatively, because again, this is something we can impact. Here was a study published recently, April 2017, in the Annals of Surgery, 642 patients who were confirmed to be opioid naive. So these patients had not filled any prescription opioids in the 30 days before their surgery. And this excluded patients who had a past history of opioid misuse or patients who had post-op complications and might have needed more opioid. So this includes 5 procedures that you can see here. And what they found was that only 28% of these of these pills were actually being used. So on the low end, the partial mastectomy patients used 15%, and lap chole patients used 33%. So we prescribed about 17,000 pills. Based on their calculations, only about 7,000 were needed. So that's 10,000 extra pills floating around with just 642 patients. And again, these are coming from well-meaning physicians and prescribers trying to take good care of their patients, but unfortunately the pills aren't being used, and so now they are a source for diversion. We also, beyond just looking at the excess number of pills, some other researchers try to take a look at how many patients are going on to continue using opioids persistently after surgery. So Chad Brummett and his colleagues published a paper in JAMA Surgery that looked at insurance claims of about 36,000 patients who underwent a variety of surgical procedures. They actually did include in their study those patients who filled opioids that month before, because there are some surgeons who like to give out a prescription preoperatively so the patient can have it filled in time for surgery. But they excluded patients who had filled opioids in the preceding 11 months. So we're eliminating those patients already on chronic opioid therapy. And they looked at patients who were still using opioids, greater than 90 days postoperatively. Interestingly, I'm not going to go through the list of procedures here, but you've got your major surgeries on the bottom and your minor surgeries on the top. The rates of persistent opioid use are similar between the two groups. We're hovering at around 6% of patients having surgery, regardless of complexity, are going on to continue using opioid medications at 3 months post-op. So this tells us there's more at play than just the actual surgical complexity that's leading patients to continue using opioid medications. Now, his group looked further and tried to identify risk factors that seem to identify patients who might be at higher risk for persistently using opioids. And here's kind of what they came up with. Tobacco use, obviously alcohol and substance use disorder may predispose patients. Medical comorbidities more medical comorbidities seem to indicate patients were more likely to continue using opioids. The last 3 here are important to point out: anxiety, depression, and pre-op pain disorders. Because if you'll remember looking back at our patients more likely to have chronic pain after surgery, this is chronic opioids. Looking at our patients with chronic pain, these were also risk factors for patients going on to have chronic pain. So the presence of perioperative mood disorders and pre-op pain conditions. So we have identified factors that seem to put patients at risk. Again, as we talked about earlier, we have these nice lists of risk factors, but many of you can probably identify patients that you think are at risk without even running through a scoring system. They walk in your office, you meet them for the first time, and you know this person might struggle with pain afterwards, and I'm a little bit worried about medication. So your spidey sense is probably more spot on than some of these indicators that we have. So we're being beat over the head with this: please stop using opioids, cut back your opioids, here's some new laws to prevent you from giving so many opioids. But we know they're good analgesics, so what do we do to treat our patients who have pain if we're being told repeatedly that we need to limit the amount of opioids? Thankfully, there are some other medications and non-medication strategies that can be used, so we're going to spend kind of the last half chatting about those things. We're going to start with old tried and true acetaminophen. So Tylenol has been on the market for a long time and has been used for many different reasons. A lot of people don't give Tylenol any credit because it's over the counter. Patients in particular often say, well, I'm not going to use Tylenol, that doesn't work for me. But we do know that it has a role in a multimodal analgesia strategy. We think it works via cyclooxygenase with predominant effects on COX-2. And the nice thing about Tylenol is that compared to some of our other analgesics, the side effect profile is pretty good. You, of course, have to be careful in patients with liver disease. But aside from that, we can use Tylenol pretty safely when we're keeping it within appropriate dosing ranges. So 4,000 milligrams within the healthcare world. And then they're now advising patients at home to limit to 3,000 milligrams per day. There have been some studies specifically looking at its effectiveness as an analgesic in post-op patients. So here's single-dose Tylenol in a meta-analysis published in 2015, and across the board, it made an improvement. So patients had decreased pain, they were able to reduce their post-op opioid consumption, and they had reduced post-op nausea vomiting. So those important things that we're trying to achieve with multimodal, better pain relief, reduced doses, reduced side effects, Tylenol had a role in that. So we know that Tylenol is a good addition to a multimodal pain strategy. NSAID medication. So this is the next big class of medicines we're going to talk about that many of y'all are probably very familiar with. They also work via cyclooxygenase. They come in two varieties. We've got the non-selective NSAIDs, which are ibuprofen and Toradol, among others. And the selective NSAID most commonly used is Celebrex, that y'all are probably most familiar with. The COX-2s, like Celebrex, were developed because of the side effects that were seen with the non-selective NSAID. So specifically, issues with the GI tract were noticed with the non-selective, so they developed COX-2s and had hoped to reduce those potential side effects. So we're going to discuss the side effects in just a few minutes, but let's first start by talking about their efficacy as analgesics. Anecdotally, we probably all know this. I think, ibuprofen is the greatest drug ever for any pain that I have, basically. But it's also been shown to help with postoperative pain. So this is just single dose use of ibuprofen in the post-op pain, and this is compared to placebo. So what these researchers were looking to see was a 50% reduction in pain compared to placebo. Two number needed to treat that I wanted to point out here, because this is pretty impressive. So 400 milligrams of ibuprofen, a number needed to treat of 2.5 patients to have a 50% reduction in pain. 200 milligrams of ibuprofen, 2.7. I will point out down at the bottom there, 800 milligrams, the number needed to treat was only 1.6 patients. But that study only had 76 people, so I'm not sure if we can use that as kind of making a broad recommendation. But this kind of highlights that these are effective analgesics. In this study here, there were no significant differences in side effects between these different doses of ibuprofen and placebo. But again, keep in mind, this is just a single postoperative use in this particular study here. Let's start talking about the side effects a little bit, because this is what I think really scares people about using NSAID medications, particularly in the perioperative period. And they're worth thinking about because they can have significant, your patients can have significant issues with NSAID medications. So we're going to go through a couple of these in more detail than others. But I do want to get started by talking about the gastrointestinal side effects. So this is one that a lot of people worry about with using these medications. So here is kind of a busy slide, I apologize. So a meta-analysis from 2012 had about 7,600 patients. They looked at both non-selective NSAIDs and COX-2 inhibitors, specifically Celebrex. They had young patients, they had older patients, and they had a wide variety of duration of use, 2 weeks up to 24 weeks. They were looking at the risk of minor GI events as well as major GI events. So minor GI events were dyspepsia, nausea. Major GI events were perforation, obstruction, and bleeding. And what they found was that the minor GI events were really similar between the non-selectives and the selectives, and then the major events did have a slightly reduced risk when you use something like Celebrex, but that was only in high-risk patients. So a high-risk patient would be a patient who had a previous GI event, someone who's age greater than 60, and patients who were also taking aspirin. So there is a suggestion that if you have a patient who's at high risk and you would like to use an NSAID medication, consider using with a PPI to help reduce the risk of GI side effects. Bleeding is another one that's obviously very important to you as surgeons, and there have been some studies looking at the rates of bleeding with both non-selective as well as selective NSAID medications. We're going to start by talking about Toradol, or ketorolac, because this is one that we commonly use in the perioperative period, specifically if you've got someone who's NPO, but you really want to, try to use your as many types of analgesia as you can. So here's a meta-analysis from 2014. They looked at using Toradol in a control group. They found no difference in post-op bleeding between these patients, so 27 randomized controlled trials. Another study published in 2017, also exhaustive study including lots of information, they said there was no association between Toradol and perioperative bleeding when you used it safely. So safely being a max dose of 120 milligrams a day and no more than 5 days duration. There was a slightly prolonged bleeding time in elderly patients and those undergoing tonsillectomy. COX-2 inhibitors, so the selective ones, what about their impact on bleeding? This would again be something like Celebrex. So here is a meta-analysis, 2017, looked at about 2,600 patients, lots of different types of procedures, and they had their patients continuing Celebrex up to 3 weeks postoperatively. There was no increase in intra-op or post-op bleeding and no evidence of platelet dysfunction found in this meta-analysis. So here's kind of some reassuring information about the risks of perioperative bleeding in patients. This is not to say the risk is zero. It is not zero. So obviously you have to use some clinical judgment with the patient that you're taking care of and determine if the risk is, if your patient is high risk, low risk, or if it's a risk you're willing to take on. Renal function is another one that a lot of folks are worried about with the use of NSAID medications in the perioperative period. It can cause some renal function abnormalities through its action on prostaglandin inhibition. In patients who are high risk, this would be people with pre-existing renal disease, liver disease, other medical comorbidities. It can be linked with fluid electrolyte disturbances. Acute renal failure has been seen, nephrotic syndrome, papillary necrosis. So again, these are your high-risk patients that you probably would avoid the use of NSAID medications anyway. But when used in healthy patients who have normal renal function, ketorolac specifically was not shown to cause significant or measurable adverse renal outcomes. So there may be a slight reduction in renal function perioperatively, but it wasn't known to have clinical significance. Again, this is in healthy patients with no pre-existing renal disease. Other potential side effects, which I won't belabor all of these, and I didn't do an exhaustive literature search, but you do have to be cautious in patients with cardiovascular risk factors. There are potential for thromboembolic events with the use of NSAID medications. Anastomotic leak is something y'all are probably much more familiar with than I as far as the literature in colorectal surgery. There have been concerns raised about NSAID medications and anastomotic leak. And then also bone healing. Again, the orthopedic and spine surgeons probably have a lot more experience with this, but this meta-analysis that was published in 2017 found that there was no evidence of impaired bone healing with use of ketorolac in the perioperative period. So I think some animal studies were suggestive that this may be an issue, but human studies have not necessarily confirmed that to be concerning. So here's just kind of one last look at these types of medications, Tylenol and NSAID medications, when compared to opioids. So this is a meta-analysis published in 2005, included a variety of surgical procedures. When they combined all the data there, the take-home message was that with using a multimodal strategy, including Tylenol and NSAID medications, both selective and non-selective, we were able to reduce 24-hour morphine consumption. And this is important because across the board, we are trying to reduce our use of opioid medications, both from a side effect profile standpoint and also to try to eliminate or minimize patients' exposures to opioid in the perioperative period because we don't want them to go on to become a chronic opioid user. We're going to talk next about kind of different medications. Everyone's really familiar with Tylenol and NSAID medications, but the gabapentinoids you may or may not be as familiar with as a post-op pain management strategy. We're all very aware that this can be helpful for chronic pain, but it can also be useful for acute pain as well. And gabapentinoids is the term that includes gabapentin or Neurontin and pregabalin Lyrica. So gabapentin and Lyrica, the names most commonly used. Those are the two I'm referring to here. They were originally developed as anti-epileptic medications, but they were actually determined to have analgesic benefit. We're not exactly sure how they work, but they appear to work on voltage-gated channels and inhibit calcium currents. They do have some side effects associated with them, and they're not to be minimized. Sedation is probably the most common side effect. Patients can also have lower extremity edema, and you have to be careful in patients with renal insufficiency. Just adjust the dose for creatinine clearance. Up to date, it has really nice a table laid out for what is their creatinine clearance, what is the dose you should use. So both Lyrica and gabapentin need a dose reduction in renal patients, but they can be used safely. Again, we know that they're helpful for chronic pain, but here's some studies that suggest they're also helpful for postoperative pain. So 2007 systematic review included 23 randomized controlled trials. They showed a reduction in postoperative pain scores in the first 24 hours post-op. They were shown to be opioid sparing, so you could use a little bit less opioid medication, but interestingly, there was no reduction in opioid-related side effects. It's possible that the sedation that is often associated with opioids was still present because it's also a side effect of gabapentin or Lyrica. So tough to say there, but we were able to use less opioid medication. Another systematic review published in 2009 Also found reduced pain and reduced opioid consumption, but again, no effect on post-op nausea, vomiting. I will say gabapentin, every now and then patients will say they have some GI upset, so there is potential for nausea with gabapentin or Lyrica. So we've just talked a little bit about its efficacy in acute pain, but it also has some data that suggests it can be helpful to prevent development of chronic postoperative pain. So here's a look at patients undergoing inguinal herniorrhaphy. They were given 1,200 milligrams of gabapentin preoperatively, which is a whopper of a dose, but this is what they used for this study. The patients said their pain was better immediately post-op, at 1 month, 3 months, and 6 months post-op. So these are patients being given gabapentin preoperatively that have improvement in their pain in the long term here, at least at 6 months. Again, reduced opioid consumption, and the patients said they were happier. So y'all are sitting here like bored to death. These studies are great and all, but y'all are probably saying, well, what exactly do I order? How does this translate to how I take better care of my patients? The data is good and all, but how do we actually, what do we do for our patients? So I'm going to just kind of suggest to you what I might do if I saw a patient postoperatively from a multimodal strategy. And I start off by recommending the hard hitter, scheduled Tylenol. And I highlight the word scheduled because this is really important, that we schedule the multimodal medications. Probably 1 out of 20 patients are going to choose Tylenol over Percocet when the nurse offers them a pain medication as needed. But we know they can be helpful. So unless your patient has a contraindication, schedule the Tylenol. You can do it anywhere from, there's a lot of different dosing strategies. You can do 650 milligrams every 6 hours, every 8 hours, 975 every 8 hours. We just want to stay under that max of 4,000 milligrams a day. You want to schedule an NSAID medication if your patient has no contraindications. Again, patients are less likely to ask for their non-opioid when they have an opioid available. So let's schedule it, make sure they're getting it because we know it helps. Again, you can use a non-selective NSAID like ibuprofen. You can use a selective NSAID or COX-2 inhibitor like Celebrex, or if your patient's NPO, you can use ketorolac. I didn't actually include the study here, but I do want to comment on it briefly. The dosing of ketorolac, y'all may be aware of the literature that's now suggesting that there doesn't appear to be any benefit when using 30 milligrams of Toradol compared to 15 milligrams of Toradol. So certainly with all of our medications, we should err on the side of a lower, safer dose if possible. So I've changed my practice after kind of coming across this literature, so now I recommend that patients get 15 milligrams of Toradol per dose. Gabapentin. So again, we've commented this can be helpful in postoperative pain. You don't have to have just a chronic pain patient to think about using gabapentin. So as far as this medication, I tend to be a little bit conservative because of the sedating side effects. This is particularly important in patients who might be getting a lot of other sedating medicines like opioids. A lot of our patients are also on benzos from home, or maybe we're using them briefly in the post-op period. So it can also cause sedation, so you just want to be cautious. So I usually start it at bedtime. In a patient who doesn't take gabapentin normally, I would start 300 milligrams at bedtime. They may still have a little bit of that kind of hangover feeling the next morning where they're a little bit groggy, but that some patients tolerate it no problem. If a patient's already taking gabapentin, please restart their home dose. We don't need to cut it back to 300 milligrams at bedtime. If they come in on 900 3 times a day, restart that medication unless there's a medical contraindication. I usually titrate up every 2 to 3 days, but if a patient is struggling with pain and they're not having any side effects, you can titrate it up faster. A kind of starting dose would be 300 milligrams 3 times a day, so we can kind of work our way to that dose. If you have a patient who is advanced age or they're really sensitive to medications or you're really worried about sedation, err on the side of a lower dose. So 100 milligrams would be a good dose to start with in a more sensitive patient. Opioid therapy. So I'm just going to make a couple comments here. I'm not going to belabor this because there's a lot of different dosing strategies. But in general, if you have a patient who's opioid naive, start low and go slow, okay? If they're tolerating PO, give them PO medications. There's no indication that IV medicines work better than oral medications. Start with low doses, oxycodone 5 milligrams, morphine 15 milligrams, oral Dilaudid 2 milligrams. Also on the IV dosing with the IV Dilaudid, err on the side of lower. You may find your patient doesn't need a milligram of Dilaudid every 4 hours. So see if you can get away with a little bit lower dose because we're going to obviously reduce side effects if we're able to reduce our dose. If you have a patient who's a chronic pain patient on chronic opioids, restart their home opioids. We don't need to recreate the wheel. We know what they're already taking. This is their baseline opioid needs so that they don't have withdrawal. So if your patient takes, even if it's crazy, if you've confirmed that this is a home dose, either by the Controlled Substance Monitoring Database, you've called their pharmacy, you've looked at their pill bottle, restart that medication if they're able to take PO. There's not great guidance as far as how do you do a PRN in a patient on really high dose opioids, but a rough estimate is using about 10% of their daily dose as their PRN dose every 4 to 6 hours. We're going to spend just a few minutes talking about what your anesthesia colleagues can bring to the table for perioperative pain management, because it's, y'all are able to impact kind of pre-op and post-op medications, but intra-op is important too. And obviously in the care of a surgical patient, it's a team effort. So, and this is also something y'all are going to start to hear more about in the coming months as some new initiatives roll out here at Christiana. IV lidocaine is an interesting medication that we're using now in the intra-op period to help patients with pain. It works via sodium channel blockade, but there also is some suggestion that it is an anti-inflammatory action as well. I didn't include a ton of literature here, but in abdominal surgery specifically, there was a paper just published in 2017 that showed with a continuous intra-op infusion, not continued postoperatively, patients had reduced pain, reduced opioid consumption by 35%. They had decreased time to return to bowel function, decreased post-op nausea, vomiting, and they were actually able to demonstrate decreased length of stay. So there's definitely efficacy for intravenous lidocaine run during the surgery. Ketamine. This is one a lot of y'all are probably familiar with, maybe from your time in the ICU or from other areas. I'll just speak on it briefly. This is an NMDA receptor antagonist. It first got popularized during the Vietnam War. They needed something they could use on the battlefield to help provide analgesia to injured soldiers. It works as a dissociative anesthetic. So what that means is the mind, the mental sensations are heightened, the physical sensations are less. So it's like an out-of-body experience somewhat for patients. I don't know personally, I've just heard this. So there are some benefits and there are also some side effects. So some of the potential benefits are it's a really great pain medication. It works very well. It has minimal effect on respiratory drive, so it's useful to use in patients who have reduced pulmonary reserve. It's a potent bronchodilator. Also a potent antidepressant. The psychiatrists are starting to use this now as infusions in the outpatient in patients with refractory depression. The side effects are sometimes what give us pause with using this medication. And again, if you've used this in the ICU, you may be aware of this. The psychomimetic effects are the ones we're most concerned about. Patients may report hallucinations. I always ask patients, is this bothersome to you? Some patients will be seeing very strange things, but they are not bothered in the least. If they are getting pain relief from the medication and it's not bothersome that they're seeing strange things, then I keep the infusion going. If the patient says, this is really freaking me out, I want to stop the medication, then of course we do. But just confirm that it's actually bothering the patient before we just stop it. You also have to be cautious in patients with increased intracranial pressure, and it can cause increased salivation as well. So use caution with patients who may have trouble handling their secretions. Here's just a paper using it as a continuous infusion for post-op analgesia. So 5 meta-analyses and 39 trials reduced opioid consumption by 40%. That's pretty significant. Reduced pain scores, although a lot of them weren't even measuring that, and there was no significant increase in side effects. There's also some suggestion that it can be helpful for preventing chronic pain. So we know it can be useful for acute pain, but what about chronic pain? So we know that's a big deal too. Here's a study looking at just that. With IV ketamine specifically, this study included IV and epidural ketamine. IV ketamine was associated with reductions in chronic pain at both 3 months and 6 months. So again, this is something we're using perioperatively, but it's having an impact far beyond the patient's hospital stay. Precedex, or dexmedetomidine, is another one y'all are probably familiar with in the ICU setting. Alpha-2 adrenergic receptor agonist, like clonidine, but much more specific, so reduced side effects. Again, used as a perioperative or intraoperative infusion, showed improved pain, reduced opioids, reduced opioid-related side effects. So again, all those things we want to achieve with multimodal, Precedex was able to demonstrate efficacy. Non-pharmacologic anesthesia. This, again, or analgesia, falls within the anesthesiologist's purview, but something y'all should be aware of as options for your patients, and again, something that Christiana is going to start to focus on a little bit more in the coming months to years. Again, I'm not going to belabor a lot of these because you're probably familiar with neuraxial and peripheral nerve block, and I'm going to talk about 2 kind of newer techniques. Epidurals. Typically, we use them for patients with open procedures who don't have a lot of physiologic reserve. briefly, they are effective. So here is a meta-analysis with 100 trials published in 2003, several different types of surgeries. All surgeries, all time points, it was better than just IV opioids. The exception was thoracic surgery rest pain. It was equal to IV opioids. Typically, our infusions include local anesthetic plus opioids. The combination of the two works better than opiates alone. Another meta-analysis looking at morbidity and mortality. So across the board, epidurals seem to improve certain endpoints that might have been unexpected. Cardiac arrhythmias, DVTs, pulmonary function, ileus, nausea, vomiting. But there were increased rates of side effects that we know are associated with epidurals. So hypotension, urinary retention, itching, and motor blockade. So choose your patients wisely, but an epidural is definitely something that we want to have available to offer our patients because we know it's effective. Peripheral nerve blockade can be useful for extremity surgeries, also starting to become used more commonly with thoracic and abdominal surgeries. You can do a single shot or a continuous catheter technique. Across the board, improvements are noted when we use peripheral nerve blockade as part of a multimodal strategy. I won't read all these off to you, but they're all good things. We want our patients to feel better after surgery, mobilize earlier, get out of the hospital faster, and be happier and more satisfied with their procedure overall. Again, briefly looking at pain scores here. So catheter is the dark line, opioids is the light line. The pain scores are reduced at 24, 48, and 72 hours in patients who had a peripheral nerve catheter. Side effects were reduced compared to opioid medications, with the exception of the sensory motor block, which of course we don't expect with opioids, but we do expect with a catheter. TAP block, so transversus abdominis plane block. This is something y'all may or may not, I'm not sure how commonly it's being done here, but this is an option available for abdominal wall analgesia. So this is blocking the cutaneous nerves of the abdominal wall. It's not going to provide visceral analgesia, but it can work for patients who maybe don't need an epidural or if an epidural is contraindicated for whatever reason. It's a fascial kind of plane block. You can see the arrow there indicating you're looking to go between the internal oblique muscle and the transversus abdominis muscle there. It's typically ultrasound guided. It can be done as a single shot. It also can be done as a catheter. Here's a meta-analysis from 2015 showing that it did provide superior analgesia compared to control, and we were able to reduce opioid consumption. PEC blocks is another one that's kind of come into Christiana. I'm not sure if it's being used right now or not, but if it's not, it's coming. This is another fascial plane block. It can be used for certain chest surgeries, targeting, there's kind of two different approaches here. You can see the lines on the ultrasound image there, targeting lateral and medial pectoral nerves, intercostal nerves, long thoracic, and thoracodorsal nerve. Randomized controlled trial published in 2015 had patients undergoing modified radical mastectomy. They either were randomized to PEC block plus general anesthesia or general anesthesia alone. The patients who had the combination did better with regards to pain and as well as side effects. So reduced pain scores, they were able to reduce the intra-op opioid, the post-op opioid, as well as the side effects. So in summary, there's a lot of evidence to suggest that multimodal analgesia is better for our patients, better for pain control, better for post-op recovery, better patient experience, and also equally as important is reducing the patient's both exposure to opioids as well as their use of opioids in the post-operative period and after discharge, because that has really broad health or implications for all of us if we can overall reduce the use of opioid medications. There are a couple of things, I'm going to really quickly zoom through this so we have a minute for questions, things that are in the works here at Christiana to kind of improve the way we provide perioperative pain care. So there's a new perioperative pain management committee that's being led by Dr. Matthew Powell in anesthesia. His group is hoping to develop some surgery-specific pain guidelines. So what this means is, some of y'all are probably aware of the enhanced recovery after surgery protocols that are out there in the world. This is kind of focusing on the pain aspect of that, trying to develop some protocols that we use for certain procedures. His goal is to eliminate the barriers to providing those things. Apparently there are issues with pre-op delivery of medications. How do we order things? How do they actually get given to the patient? His goal is to reduce the barriers so we can actually use these techniques. And then the plan is to follow outcomes, see if our patients actually do better when we implement these strategies here. With regards to opioids, he'd also like to track the number of postoperative opioids that patients are getting so we can see, are patients using these medications? Are we in line with what other people are prescribing for certain procedures? So that's kind of some of the main aims there. Myself, along with a lot of other people, are also working on just pain education in general. So we've got stuff, I'm working with Dr. Rubino on a project to try to provide pain management education to providers, hopefully some sort of CME offering so that y'all can get your learn on about pain again. I'm also working with others on nursing education and patient education, because that's a big part of this, patient expectations. They often come to the hospital expecting to get certain things, and if we can educate our patients on why we're doing things a little bit differently, we may get a little more traction with our patients. So there's a lot of things coming, and it's going to be an exciting time for Christiana and pain. Exciting pain, yay. All right, what questions can I answer?
So I want to introduce myself, Caitlin Halbert. We've actually been communicating
yes,
via
by pen
email.
pal.
And I want to thank you so much for helping the bariatric team with our pain protocols. We just launched them actually this week, and so you guys should have all gotten an email. And we're using, multimodal approach for our patients, excluding NSAIDs, but allowing Toradol, of course. So I think that it's really important for the residents to hear your talk today, because they could take that and apply it to every patient that they admit to the hospital. So hopefully everyone was listening very carefully. A couple of things. So one is the use of IV Tylenol. When are we going to do that?
Yeah.
Is that going to happen?
It's a good question.
And the other question I have is, I did my fellowship up in New York, and they had a 5-day rule, basically, for all providers that were not pain specialists. So you could only prescribe a max of 5 days of narcotics, and you could only prescribe it electronically. So there was no pharmacy shopping for our patients. So 2 really important concepts, I think. And do we see that happening here at Delaware? If it's not, is it something that you would encourage?
Yeah, so first question, we'll talk about IV Tylenol. So I get asked this about once a week, and I don't claim to be the person who's in charge of this decision making. I'm very far from it, but I am aware that this has been asked a lot. A lot of people are really interested in this. It has been denied by P&T committee many times over the years due to concerns about cost. Also, some of the research has indicated it doesn't actually improve outcomes or reduce opioids. So that has probably been the basis for why its use has been limited. And it may be that us as providers, we're not using it appropriately. Maybe our patients actually could be reducing opioids, but maybe we're just like, oh, we always give Oxy 5 Q4 hours, and that's why patients continue to use the same amount of opioids. Maybe we aren't changing our practices when we're using it. But it is being introduced at the Middletown ED. It has just been approved for use there. So this is going to function as maybe like a small trial where they're trying to look and see if it actually does reduce the amount of opioids they're able to use for patients. So this may be like a crack in the door. We got our foot in the door for using IV Tylenol. If we can demonstrate it's helpful there, perhaps P&T will consider bringing it to the rest of the hospital. The second question about should we be limiting use of opioids, and if you need them longer, you need to see a pain physician. I think that's interesting. I'm not sure. I think 5 days might be a little restrictive. I have not personally had surgery, but I've taken care of a lot of people in the pain world where I don't know that many of the surgical recovery patients are really out of that acute post-op pain window in 5 days. And as a pain person, sometimes seeing these patients as an outpatient, I felt uncomfortable seeing people that were acutely post-op. Am I missing a post-op complication? Is this increased pain to be expected, or is this something I'm missing? Do I need to call the surgeon and say, you need to see your patient today? I'm not sure. So I do think it's worthwhile as a surgeon to say, this is my endpoint. I'm going to provide your care until this point. So you don't become the patient's chronic pain doctor. A year later, you're still prescribing monthly opioids, but I'm not sure of a great time frame for that. Yeah.
Thanks, Arena. That was an excellent talk, and I think very nicely kicks off the conversation that we're going to be having a lot over the next couple months as we get into the work that Matt Powell is leading to develop the surgery-specific pathways. I just want to highlight that much of that work, the details of those pathways, is going to be done at the section level. So for the general surgeons in the room, please make an effort to attend the section meeting next week. We'll start the conversation about this, and then over the next couple months really get into the details of what those pathways look like.
And they want your input. So this is, coming led by anesthesia, but these are your patients. So they definitely want surgeon input. Absolutely. It'd be a huge part of it. Yes.
I use Exparel in the past
Yes.
as a block, which is lysosomal bupivacaine. And I had a great experience with it, but I see that we don't have it available here.
Yes. So again, I think this decision probably was made before I came here. In fact, I'm pretty positive it was. I think that there had been a trial previously of folks using that here at Christiana, and they were not able, as far as I understand it, were not able to demonstrate improved outcomes. So they actually restricted. I was told yesterday that one surgeon is allowed to use it because his patients did seem to do better. But among the other surgeons who were using it, they weren't able to demonstrate their patients did better.
Well,
I unfortunately don't have more detail than that, so I apologize.
this is particularly for that block that you showed for the hernias.
TAP. Is that what you said, TAP?
Yes. And in those patients in particular, they have a tendency to consume opioids in the first 3 days quite significantly. When you use that, in the first 3 days, they pretty much don't use anything.
Yeah.
They come back and complain of having pain on day 3. So I don't know for anything else, but for that, it's quite good.
Yeah.
And I also had some experience with the IV Tylenol. It worked very well.
Yeah. I've used it, IV Tylenol, I've used it 2 other places I've worked. Unfortunately, at both of those institutions, the use actually got taken away from us because it was being overused, I think. So they restricted it to certain patient populations like PT-Monk. But so I have been places where we used it and we loved it. But I think the cost at those institutions didn't seem to make sense for the hospital. But we'll see. It may get reintroduced here. Speaking about the Exparel, I, encourage you, if it's something you would like to have considered as being offered, you can get with kind of your service line leadership and say, we'd like to take this before P&T, a proposal for why we want to try this again. We want to set up a trial where we're going to use it in these patients and see if we can demonstrate efficacy. Because in the hospital, we want to find things that work better. If what we're doing right now isn't the best thing, let's get some data that says we can do it better. And then I'm sure P&T would approve it if we've got data that says it works.
And the last thing is, I'm from Colombia. As much cocaine as is produced there, to find any type of opioid for a patient, for pain control, is extremely difficult, even in situations where you have patients who require it just for cancer management or anything. So we cannot really treat patients after surgery with any type of opioids, except for maybe Tylenol number 3. It's the only thing you have available.
Yeah.
Other than that, we have to use dipyrones and diclofenac and many other NSAIDs that we try to avoid here. But it's also a cultural change because people are okay with that.
There
So
is absolutely a
it works.
patient expectation that they get opioids. I'm paying, obviously, so my patient population is a select few, but the patients absolutely are expecting opioids. And that's often the most difficult part about perioperative pain management and chronic pain management is explaining to them why, yes, that's what we've been doing for the past 30 years, but it's not working, and this is why. And we have to educate our patients on why we're trying to do things differently, because here it's an expectation. In America, you will get opioids if you have something even remotely painful. So I really try to do my part for my small consult service to educate the patients on the dangers and why we're trying to do things differently. Yes?
Very good talk. Thank you. I'm a general surgeon. The total dose of Toradol, that's always an issue too. In other words, we use it and people say, oh, it can only be 1 day, 2 days, depends on their age, this, that, and the other. So the 15 milligrams sounds like we're all doing as opposed to 30. But what's the total?
So 120 milligrams a day is the recommended max. The
Right,
also
but
recommended duration of therapy is 5 days. Interestingly here, and I don't know, I've only been here a year, I'm not sure where this kind of started, but it looks like the most frequently ordered is 4 doses. I'm not sure if that's just the first click or if that's just kind of the culture here. I'd have to dig a little deeper to see kind of what the data was for that or what the decision point was that. But it's 120 milligrams a day, 5 days. That's
Okay.
kind of the recommended max days or max dose, max duration.
Yeah, most of that probably is culture because things like this are going to hopefully or ideally
Yeah,
educate
that's
us.
a lot of places. I mean, it's this is the Christiana way or this is the whatever way. I mean, it definitely becomes what you're used to doing or what you did in training, you continue to do when you become an attending.
Right. Christiana has a lot of money, too, so that IV Tylenol and stuff and that Exparel, that's all stuff we should be able to get.
Okay.
Anyway, typical Percocet has got the acetaminophen and the oxycodone. Do you recommend as an outpatient, because we do a lot of outpatient stuff,
Yeah.
should we be putting them on just ordering oxycodone?
Yes, that's my
separate,
recommendation. So that's
and
what I
giving
like to
Tylenol straight ahead
Yes.
4 times a day? And
Yes, I prefer to do that. Now, for some patients, it may be too much. That may be too much to keep up with remembering to take your Tylenol around the clock and your Percocet as needed. But again, we know that Tylenol is helpful. So if we can get patients to continue taking that around the clock, our hope is that they're going to reduce the amount of oxycodone they're using. So yes, my recommendation, and when I have an outpatient pain practice, I just prescribe oxycodone plain. Unless a patient comes to me already on Percocet and it's all that works or whatever, I will just provide oxycodone plain.
And lastly, I'm sorry, are you somebody who is an outpatient person, or are you just hospital-based?
I'm just hospital-based. So for those that aren't aware, I've been here a year now. We have an inpatient pain consult service. So please consult us on your complicated postoperative pain management patients. Please don't call me with everyone on opioids. I can't see them all. But if someone's really complicated, just pain service on Vocera, please put in a call. We'd be happy to help. It's myself and one nurse practitioner. Okay, so it's the 2 of us. But we are hoping to expand. We're bringing on more people to our team, and we're hoping to provide an outpatient clinic, perhaps as early as the fall, although it will be a very small version of what we ultimately hope it will become, because again, there's just 2 of us. But yes, we're hoping to expand, but right now we're only inpatient.
And I'm sorry to one last thing. As far as like the big picture, with the chronic pain and things like that, I think that was great, the education beforehand. If you had pain before, you're going to have it after, blah, blah, blah. But those that have, that's a high number, it seemed like, for people that were going to have chronic pain after elective surgeries that didn't have pain before.
10%, yeah.
Yeah, and we definitely have to tell them that can happen, just like anything can happen.
Yeah.
But is pain management people, and this is education too, like as a surgeon, I don't want to see somebody after 3 months anymore, as far as pain goes. You're cured, everything looks great, you're healed, there's no problems. We've done all the studies. So where it is reasonable for us to say you need to see X, and is the pain management people accepting of that?
Yes. Well, so I can't speak for the community. I don't know their personal feelings on this, but as myself as an outpatient pain provider, I did not mind seeing patients who had persistent pain after surgery, after, again, other places I work, we said we wouldn't see you before 6 weeks post-op. We wanted the surgeon to make sure they're seeing you acutely in case there's an issue. But certainly 3 months is reasonable. If a patient is continuing to need opioid management or even non-opioids, having severe pain at 3 months, I think it's very reasonable to have them see a pain management person. The community physicians, I suspect, are seeing a good bit of those patients. I mean, there's enough pain patients to go around, and they're not all surgical. But myself, I never minded seeing a postoperative patient who was still struggling, because a lot of times there are some interventional techniques that we can do for patients who are continuing to have pain. It's not just opioids. So also think about pain management. Again, we're trying to educate ourselves as well as our patients. Pain management is not just opioids. There are so many other things available for pain management. And your community pain physicians may be able to offer things besides just Percocet. We're not just script writers. We really want to think outside the box and try to do other things when we do fellowships and you're trained to do things. So I'm sure they'd be happy to see your patients. And I certainly think 3 months is very reasonable to say, I'm not going to keep prescribing your opioids or keep seeing you for pain.
Thank you. Great talk. Great job.
Thank you.
A couple of quick questions. Gabapentin. So we can just give that as a straight dose. Do you have to wean off or wean? Or
if patients are on it for a very brief period, they often can just stop it without any issues. If they're on it for long term, say a month or longer, I do typically wean it, although I've had plenty of patients just stop it cold turkey without having any problems. But I encourage them to wean it. But again, patients kind of do what they want, and there's no danger in stopping it abruptly. But for a short course of use, it doesn't need to be weaned off.
Excellent talk. Actually, we have this recorded, and Ruth Ann is going to work on getting this available for anybody that was not here. So if you can, spread this around amongst the surgical community for those people who could not make it today, and we'll also try and get like a pamphlet or your PowerPoint put together to send out to people as well for anybody who missed it. In particular, a ton of the residents aren't here, and I know you guys do a lot of the prescribing for us. One other thing, if you wouldn't mind talking a little bit about, we put a pain module together to kind of help everybody out with this process as well. So maybe you can talk a little bit about that.
So I briefly mentioned it in kind of this is what I would do. Interestingly, that closely mirrors what we're hoping to do with our postoperative pain module or order set. So when I first got here, we were tasked with revising all of the pain order sets that were available here at Christian, or at least looking at them and saying, are they appropriate? Should we update them? One of the big ones was the postoperative pain module. So Dr. Sixta, I believe, has sent out to colleagues a rough draft of what we're trying to do. And the highlights of this module are, again, the scheduled use of non-opioid adjuncts. On the old order set, there was a lot of Vicodin, Percocet use, so combo medications. We're trying to move away from the combo medications. So now on the updated order set, you will see oxycodone plain, oral morphine, oral Dilaudid. We've tried to reduce the amount of available doses, so we know that order sets encourage behavior, so things that are easily clickable in front of your face will kind of drive behavior. So we're trying to kind of keep our doses reasonable unless a patient's clinical condition warrants higher. So that's kind of the goal of the order set revision. Scheduled non-opioid medications, unless there's a contraindication, and kind of lower doses of opioids overall. You can go outside the order set and order whatever you want, but this will be an easy way to incorporate multimodal analgesia. Additionally, if you have a patient who's a chronic pain patient and they take OxyContin 63 times a day, they're going to need more than the the little oxycodone 5Q4. Okay, so you have to think about your patient as an individual, but for straightforward patients, I think the order set will be helpful to kind of guide you. All right. Any other questions? Okay. Thank y'all.